Everybody knows the great neurosurgeon Professor Iftikhar Ali Raja late. He was the founding member of ACNS, Asian Congress of Neurologic Surgery, and he was also founding member of Asian Oscillation member, which was a big international society. Credit goes to him that he introduced Pakistan neurosurgery everywhere in the world. He was one of the most active member of Pakistan neurosurgery who used to travel all over the world for the academic purposes. And he was a person who raised the name flag of Pakistan the world over. We miss him a lot. May Allah bless him in the Jannah. Now we invite our presenter, Dr. Hasan Syed from USA, Global Resident Burnout. Topic is Global Resident Burnout.
Hello, my name is Hasan Syed, and I'm really excited to be here with you today, I guess this morning in Pakistan. I was very fortunate to visit Pakistan in 2020 when the Karachi spine was going on. And again, thank you for giving me the opportunity to be here with you. My talk today is focused on education. I'm a neurosurgeon in America with a subspecialty focus in pediatric neurosurgery. But I've always been really a proponent of education and involved with resident education as well as our own fellowship in pediatric neurosurgery. But the title of my talk today is Work-Related Factors on the Risk of Resident Burnout, something that we've all heard about. And this is sort of a pilot survey that I wanted to share with you all. So I have to acknowledge my co-authors as well, Natasha Ironside, who's a third-year resident at the University of Virginia, Rocky Feldbaum, who is a cerebrovascular and endovascular neurosurgeon at Georgetown, where we both trained, as well as Walter Jean, who was our program director at the time, who some of you may know as well. He's now the chief of neurosurgery at Lehigh Valley in Pennsylvania. So as I mentioned, we've all heard about this concept of burnout and physician burnout, but I think it brings about different ideas depending on where you are geographically, and also what country you're from and what the resources are available. And even with COVID now, the concept of burnout has become more prevalent. So let me first start out in terms of describing what burnout is, and then taking us forward in terms of the study that we conducted. So burnout, as we know, is a syndrome that's characterized by emotional exhaustion, depersonalization, and a decreased sense of efficacy. It's something that we know from previous research that is present in trainees all across the world for different reasons. And in fact, our accreditation board, the ACGME, takes this into consideration, and in 2017 actually reaffirmed the 80-hour work limit, which is what is standard in America for resident training. But the ACGME really has had an increased focus on resident well-being, as well as fostering a culture of respect, accountability, and support in the clinical environment. So why is burnout important? Why are we talking about this? Well, there are many factors related to burnout, some that we have control over as educators, and some we don't, but these include demographic factors, work-related factors, as well as personal issues or concerns that come up in each of our trainees' lives. But ultimately, this can have an effect on patient care and lead to medical errors, job attrition, depression, and sadly, suicide. So really the questions are residents right to demand attention to wellness, and does it actually make a difference? Or is this just a harassment of program directors and educators? So we sought to really investigate this with the following questions. How many neurosurgery residents are at risk for burnout? And is there a difference across the globe? What work-related factors drive burnout or reduce it? Is there a difference in the effect and strength of these factors around the world? And finally, are trainees in low to middle income countries more likely to be at risk. So we devised a 16-question survey that really asked the respondents program characteristics and work-related conditions. And we also took this survey called the Maslow survey that really has been validated as a tool to measure burnout. And these 6 questions focused on emotional exhaustion, depersonalization, and the sense of personal accomplishment. The responses were then collected on a 5-point Likert type scale, and a score greater than 18 was deemed at risk for burnout. This was the results from our survey. There were 797 respondents from 93 countries, with over 240 respondents from low to middle income countries. This is a map that sort of illustrates the respondents, and we were very thankful. We had 26 respondents from Pakistan. The color red describes the non-LMIC countries, and the green are the LMIC countries that responded to our survey. Again, this is just a pie chart describing the results by geography, and you can see 39% of our respondents were from Asia, followed by 25% from Europe, and then 14% from North America. So I wanted to just briefly go through the 6 questions that looked at the burnout concerns. So question 1 really focused on the frequency of our respondents feeling frustrated. So the majority, 52%, felt frustrated sometimes, but more specifically, 23% of the respondents usually or always felt frustrated. In terms of feeling happiness or satisfied with their jobs, you can see the large majority were satisfied with their job. Question 3 focused on the feeling of being stressed at work, and approximately 38% of respondents described usually or always feeling stressed at their workplace. Question 4 basically focused on the feelings of being tired, or the fact that respondents didn't care to what happened to their patients, and 9% respondents agreed or strongly agreed with that statement. In terms of the work environment, 31% of our respondents felt that their work environment was hectic, chaotic, or out of control. And finally, question 6, 6% of the respondents did not believe that they had a positive influence on their patients or their coworkers, or their work environment was a positive influence. And finally, the 6% also felt like their training was headed in the right direction. In terms of the key findings, our global cohort, in terms of the global cohort, the average total score from the 6 burnout questions was 15.8, and the at-risk from the global cohort was about 21% that were at risk for burnout. As we can imagine, the drivers for burnout included frequency of overnight call, the total work hours greater than 80, consecutive hours worked, and interestingly, less than 100 operative cases in the last training year. So when we look at the results in more detail in terms of how geography influenced these findings, we saw that US and Canadian trainees, approximately 40% reported 300 operative cases in the past year. 64.8% of these trainees worked over 80 hours per week, which of course the ACGME would find surprising because that is technically the limit, the official limit. When we look at the Europeans, they reported approximately 29% reported less than 100 cases that the trainees were involved in the past year, and they were more likely to have less frequent than Q3 call. As we can imagine, Asian and Latin American trainees were more likely to have every other day call, and 22.6% of Asian trainees worked greater than 120 hours per week. So this is a table that really describes the intercontinental differences in the risk for burnout. And I want you to focus on Europe and US and Canada. So Europe, 26.9% of residents in that location were at risk for burnout, compared to 11.2% in US and Canada. And so you all might be wondering, like, how is that possible? Globally, work hours and overnight call are burnout drivers. However, the European trainees have a 48-hour work week. So why do they have the highest burnout score and the highest percentage at risk for burnout? And the reason for this, at least what we think, has to do with the data that we analyzed, and that goes back to the number of operations that these trainees have been involved in last year. If you look at the US and Canada, those trainees who were involved in 100 to 300 operative cases were actually a driver for burnout. Whereas in Europe, those trainees who were involved in 100 to 300 cases, that was actually a protector for burnout. So this probably has to do with the operative cases and trainees feeling that the more they operate, the more positive their training is, and them sort of advancing their career goals. So operative experience and burnout risk, we saw that 28.6% of European trainees were involved in less than 100 cases. Those trainees have a higher burnout score compared to other European colleagues, whereas 40% of US and Canadian trainees operated in greater than 300 cases in the past year, but were less at risk for burnout. Looking at low to middle income countries compared to non-low to middle income countries, as we can imagine, these trainees were more likely to work over 80 hours per week, had more total hours per week, and more likely to take call every other day. This is just a graph sort of explaining the difference between these questions between low to middle income countries versus others. And the fact of the matter is most of the responses were similar. However, low to middle income countries were more likely satisfied with their workplace, but described their environment as more hectic. So despite that, low to middle income countries had identical burnout compared to low to middle income countries. And that was quite surprising because these trainees are working harder, longer hours, and more often on call. So again, why do they have identical average burnout scores and percentage at risk compared to the rest of the world? And our explanation to this is the fact that LMIC trainees may be immune to these global drivers, and this all relates to comparative perception and potentially the concept of grit, which you all may heard of. This is really described as a continued fortitude in the face of hardship, and as well as perseverance of long-term goals despite adversity. So this may play a role in the resilience that neurosurgical trainees experience from LMIC countries, and something that we can all learn from. Certainly, there are limitations of this study, as there are with all surveys. This was also a truncated survey and wasn't validated, but definitely I think we can all learn some things in terms of what low to middle income country trainees are motivated from, and something that we can pass on to our own trainees. So really the conclusions are work hours and on-call duties drive burnout throughout the world. The impact of these factors differ geographically, as we talked about. Operative case volume has a significant impact, and the paucity of operative experience may be a more powerful driver to burnout than work hour restriction is a protector against it. Trainees become more resilient to working long hours if they perceive their operative experience to be advancing their training goals. Finally, LMIC residents really experience and show us the concept of grit and resilience. And perhaps, you know, from the US, our accreditation council is vindicated because of the US's, the US trainees sort of work hours and their burnout risk. Again, I want to thank you all for giving me this time to share this work. I'm happy to answer questions. Again, I thank the organization committee. I also want to thank Dr. Salman for all the work that he's done and the introductions that I've had in terms of meeting everyone from Pakistan. And I hope that I can visit you all very soon. Thank you.